Good morning, everyone. On behalf of the Community Health Impact Coalition, I really appreciate you getting up early and joining us this morning for this really important convening. From words to action, winning the budget line for professionalised community health workers. The Community Health Impact Coalition is a team of community health workers, allied organisations working in over 60 countries, and you'll hear us call it chic, in case you hear that term. We come together to make professionalised community health workers the norm worldwide by changing guidelines, funding and policy. I'd like to welcome today Ministers of Health and representatives from countries such as Malawi, Cote d'Ivoire, Burundi and Uganda, and also colleagues from the Global Fund, USAID, PEPFAR, Africa CDC. There are so many familiar faces in the room. It's exciting to see you all. But if I've not had the pleasure of meeting you, my name is Liz Jarman and I'm the CEO of Living Goods. And I'm joined by my colleague here, Julius Mbeya, who's the co-CEO of Lwala Community Alliance. So Living Goods is a global organisation but headquartered in Nairobi, Kenya. And we're dedicated with partnering with governments to ensure women and children don't die from easily preventable and treatable diseases, and that life-saving care is available at the doorstep. And for the past 15 years, we've been partnering with African governments to ensure that community health workers have the tools, the support, and knowledge needed to be successful and to truly reach their full potential. And today we support over 10,000 community health workers, serving 6 million people in Burkina Faso, Kenya, and Uganda. And I wanted to bring to life what we mean by a close government partnership. And money talks. In Kenya, we work very closely with the governments, and in 4 of the county governments, they are actually spending $6.5 million contributing to our joint community health program. That's 60% of the costs. And in leading Living Goods, I've really seen the power of radical collaboration. When we unite, whether it's governments, funders, other implementing partners, and the communities in which we serve, and we really have a deliberate focus on forging strong alliances instead of competing, then we really can be transformative in the change that happens. And in this room today, we are all trying to tackle monumental challenges. And this really requires us to be bold and innovative. And that is only ever going to be possible with shared dedication and collective efforts. So that's why in 2019 even, Living Goods joined with 5 other organisations together in founding the Community Health Impact Coalition, CHIC. And in amazing 4 short years, it's really grown. There are now dozens of organisations, thousands of community health workers, and in over 60 countries. And radical collaboration is a core principle of CHIC. And I truly believe it's one of the reasons for the great success in terms of mobilizing global health community to make professionalized community health workers the norm by changing those international guidelines, increasing global funding, and winning national policy. So let me turn to my colleague, my friend, my neighbor, Julius, who can share some examples of radical collaboration of the work we've done together in Kenya that has resulted in some national policy wins.
Thank you, Liz. I wonder the difference between just collaboration and radical collaboration. And it's the radical part that I'm going to be sharing with you this morning. My name is Julius Mbeya. I am the co-CEO at Lwala Community Alliance. We serve in the same country, Kenya, as Living Goods. And I want to share with you an example of what can happen nationally when organizations like ourselves come together to push a common agenda and to achieve something that is so transformative. We drew our inspiration from SHIC because as organizations working and collaborating globally, we looked back home and we said that similar needs to happen. And so we founded something called CHU for UHC, Community Health Units for Universal Health Coverage. This is a collection of community health organizations working in Kenya. We are now numbering about 26 of them, and we have centered the Ministry of Health as the leader in that collaboration. We have a shared vision for professionalization of community health workers in Kenya. And for that reason, we have a shared agenda that we have consistently pushed together to ensure that what we are professing as SHIC globally can actually also be the reality in Kenya. We drew our principles and commitments from SHIC principles around CHU professionalization. We want to see paid, supervised, equipped, digitally empowered community health workers delivering proactive care to households across Kenya. And I'm glad to say that we are actually winning. I think Kenya is on the map right now in the debate and commitments that are being made towards professionalization of community health workers. We built our momentum from the COVID-19 response. Through the COVID Africa Fund, our CAF initiative, we demonstrated to the Ministry of Health that organizations can actually come together to support a national agenda. Organizations like ours, working in specific geographies, rose to the occasion and ensured that community health workers across Kenya were protected in the midst of the pandemic. We are developed trust with the Ministry of Health. They have seen us as collaborators. We have pushed for policies and have achieved big wins around that. We have ensured that community health workers are counted and that we have a CHW registry that is available and agile and updated in Kenya. We've also developed national tools, and when you hear about the electronic community health information system, Kenya is on the course to becoming one of the countries where all the 100,000 community health workers are digitized. All these are possible because when we meet like this, when we make commitments, those commitments need to be translated into action back home. Today, the government of Kenya, through the president, has severally and made commitments to the 100,000 community health workers. They have committed to equip community health workers, which means giving them kits and the tools and the equipments that they need to deliver services. They are going to be digitized, which means that they will be given phones and a digital platform to work with. And they're going to be paid, sharing the responsibility between the national government and the county governments. What has made this possible? In my opinion, one of the main things is that we have centered the leadership of the Ministry of Health. We are working through the system rather than outside of the system. We are pushing from within so that whatever we are putting forward is believed and can actually be demonstrated to be working. We have maintained political engagement because budgets are political. We have to engage the different departments of government, from the Senate, the National Assembly, to the Ministry of Health, to ensure that the commitments that we are looking for can actually be delivered. We have remained persistent, which means that this is not an agenda that you start today and drop it while you are out of the room. It means that it's something that you have to maintain and mainstream in your policies, in your budgets, in your work plans, in your everyday work in CHWs. We've also occupied strategic positions, being invited into national task forces and technical working groups. And that ensures that we build lasting relationships that we can actually rely on and depend on to make this work done. But we're also aware that the work is not done yet. And so we have to sustain the momentum that we have gained. We have to ensure that these promises that have been made actually translate into reality. And in about a month, the President will be making public some of these commitments that have been made in a national holiday, and we hope that the county governments or the subnational governments will come along. Our work is cut out. As much as government has ensured or has made commitments towards equipping, digitizing, and paying, training still remains a gap. supervision remains a gap. And all these principles that we all yearn for have to be in place. And more importantly, we have to put in place policies and procedures to ensure that the promises that are made today outlast the current administration. I want to turn it over to Liz once again. And yeah, thank you, Liz.
Thank you, Julius. That was a great summary. And I think it's important to say that this work, these wins that we're seeing in Kenya, they're actually not limited to Kenya. They are starting to happen in countries around the world, and they're happening at a global level and a regional level too. And I think that's why Chic is moving past saying, if community health worker integration in national, if it's possible, to how can this work? How can integration be achieved? And so that's why today we've invited a lot of collaborators. Welcome. Here are some collaborators we've welcomed. They include government officials, they include funders, they include technical partners, they include philanthropic organizations, and of course they include the community health workers themselves. We're coming together to discuss the process of winning the budget line for community health. This session really aims to explore successful financial models. It aims to get into the details of what strategies are needed to shift the budgetary action towards integration of professionalized community health workers into health systems. And finally, we're looking to define what pro-CHW champions, all of you, can do to win the budget line at a country level. So let me hand back to Julius, who will kick off, introducing the first speaker.
Thank you very much, Liz. It gives me great pleasure. That is a word used by politicians, but I'm really delighted to introduce to us one of the faces, a representation of the workforce that we talk about, community health workers. Please welcome Bupe Sinkala, a community health worker who is part of the CHIC and who is going to talk to us about her work. Welcome, Bupe.
Thank you so much to Mr. Julius. My name is Bupe Sinkala, and I work for African NGO Mothers to Mothers in Zambia, and I am so delighted to have been invited to speak today, because no genuine talk of achieving universal health coverage by 2030 would be complete without truly including community health workers' solutions and responses. With almost 500 million people across the African continent still not accessing basic health care, the care they need, now is the time to turn words into action. For us community health workers, that means 3 things: investment, support, and recognition. And all of these require a budget line, not as an afterthought, not as something to pay lip service to, but something that is built on from the start and is committed to in the long term. Why is this important? Universal health coverage depends on quality primary health coverage, which in turn relies on salaried, skilled, supervised, and supplied community health workers. In other words, community health workers plus primary health care will equal to universal health coverage. Community health workers are uniquely placed to understand and meet the integrated primary health care of the needs of their peers, ensuring that no one is left behind. Now, we must unlock the full potential of professional community health workers to deliver health for all. How do I know that? I have seen firsthand that what can be achieved when we invest in female grassroots leadership, because it's what I do every day with my fellow mentor mothers across with my fellow mentor mothers, local women living with HIV, trained and employed by mothers to mothers across 10 African countries. Since our creation in 2001, nearly 12,000 mentor mothers have reached over 15 million people across a dozen African countries. Since, with life-saving services, including maternal health, child health, reproductive health, and HIV services, and helped to keep alive more than 2 million at-risk women and children. We also work alongside nurses and doctors in health facilities and door-to-door in communities. But Zambia, like so many other countries, is facing a serious challenge and shortages that is making it truly hard to leave no one behind. There are only 11.2 doctors, nurses, and midwives per 10,000 people, well below the World Health Organization minimum recommended threshold of 22.8 doctors, nurses, and midwives per 10,000. That is 11.2 per 10,000 instead of the required 22.8. Working in the health sector is not always an attractive proposition. Too many community health workers are asked to do their work for free and have workloads that far exceeds their material and non-material support they are getting. This is why we need a much stronger integration of community health worker systems for effective, efficient, and responsive primary health care and health emergency response. And yet, half of community health workers in low or middle income countries are not salaried. According to Community Health Impact Coalition, 86% in Africa. And according to Africa Frontline First, the African continent is facing an annual financial gap toward community health of around $4.4 billion US. The World Health Organization estimates a shortfall of 4.2 million health workers for the African continent by 2030. This needs to change. We simply must do more so that community health workers as a CHW is an exciting, valued, and viable career option. What should this investment be directed towards? Equal pay, equal and fair pay, formal recognition of their status and qualifications through certification and accreditation. Better supervision and training and digital tools. Those are the things that motivate community health workers. What motivates me to work harder is to build the confidence of our community in us as professionals and deliver primary health care in a way that improves access, increases quality, and saves lives. I know this is true because my employment and remuneration as a community health worker has changed my life. As a single mom, I am able to pay for my daughter's school fees and take care of her needs. I am also investing in building my home, and my dream of furthering my studies in social work and community development is now a reality. I see the difference I am making in my community every day by delivering integrated primary health care to my peers. More people are making their health a priority. More people know about their what their health options are. More people are able to make healthy life choices as a result. As community health workers, we have shown our invaluable life-saving contribution. Our potential will only be fulfilled when the investment and health system support laid out in the Monroe call to action is realized. The time to move from words to action by investing in professional community health workers is now. It is not tomorrow or soon, it is now. Thank you so much. I will now invite John from Global Fund.
Morning, everybody. I'm not sure I can follow Bupe, but thank you for such a powerful articulation of why we're here. I'm John Fairhurst from the Global Fund. A real privilege to be here. And just such a fantastic way to start this week. We have 3 high-level meetings this week talking about universal health coverage, talking about TB, talking about pandemic preparedness. There's a huge conversation happening around climate and health. And I think it's really clear that community health workers are central to this. They are the transformation of health. We will not achieve health for people unless we support, professionalise, pay, and do all of the things that Bupe outlined so clearly in terms of the impact in countries where we all work. So really fantastic to start this week with something which is so powerful. And we really have made huge progress. Julius and Liz outlined at the beginning, we've seen many countries start to move to professionalise, to pay, and to build the sort of infrastructure that allows community health workers to work effectively. We've seen this in Malawi, we've seen this in Kenya, we've seen it in Liberia, we've seen it in Mali, we've seen it in many countries, the progress that we've made. But as Bupe outlined, there's still a lot to do. There are still many things that are not happening in countries that we need to happen. Many things that support the kinds of impacts that we know. And we know this works. We know that building a functioning community health system that's supporting community health workers doubles immunisation. We know that it brings 10 times the attendance of skilled birth attendants at delivery. We know that it transforms malaria diagnosis and TB diagnosis and HIV diagnosis. So I think the question is, why is it taking so long for this? Fantastic we have this momentum, but how do we accelerate from where we are today? How do we dive further? Which is the question that I was asked. I'm not going to answer it. I'm going to give you some suggestions around how we do it. I think, obviously, the point here is this has to be collective. It's fantastic, and I want to thank the ministers in the room for being here. They're so central to this conversation. The community health workers so central to this conversation. The question for many of us who sit in the middle is how do we support and accelerate this transition? We think there are 3 sort of core strands that can really drive change here. One is readiness. We need countries to be ready. They need to be able to scale. They need to be able to absorb an increased level of funding. Really central. The second is funding, obviously. We need scaled funding, but we also need scaling funding, and funding that's done in a really different way to create change. And lastly, and I think the most important one, is we need this to be led by countries. It's really central to both the transformation, but also the long-term sustainability, that countries are in the driving seat around what changes what we do. So readiness. Readiness is about the maturity of the system. I think any ministers of finance or financial people in this room would say, in terms of increasing financial commitments to anything, that thing has to be ready to absorb more funding. It has to be able to scale in an effective way. It has to drive impact. For ministers of finance, it has to drive economic return. And so community health systems have to be able to demonstrate this to ministers of finance. They have to be able to demonstrate that they have the basic tenets of what makes them successful: the registers of people, the ability to pay, the systems, the digital tools that allow people to be effective. And of course, a plan for sustainability. Making short-term investment is driven by knowing that you will have a long-term plan, a long-term success. So we have to be mature and ready. It's one of the reasons we've launched a catalytic fund with Africa Frontline First and SCOL and J&J, which is going to put $100 million of funding in the next 3 years into helping countries build that readiness, helping them build the maturity of systems that allows them to scale much more rapidly and radically as we move forward. The scaled and scaling funding is obviously a follow-on and a core component of this. It's important that funding moves from being piecemeal. We have to be more system-orientated in how we fund. We have to build the coherence of systems. We have to move, not to stop innovation, but we have to move to scaling innovation so that it's successful and reaches people in countries. We have to move from vertical funding to polyvalent funding. We have to enable people to be multifunctional in what they do. And it means that we have to be coordinated. And that leads me to the next and most important, I think, piece, that this has to be led by countries. We have to put the countries in the driving seat as donors. We have to listen to their agenda, follow their national plan and their national budget, and make sure that donors are coordinating to leverage our skills. As donors, we are different. We are not an homogeneous group of organizations. We have different capabilities and different skills. So let's use that value and difference in our agenda to support countries in delivering their agenda, their plan. One of the things that we're doing is working with USAID, with David and others, to try and coordinate, also with philanthropic donors, a much more effective way of aligning on investment plans in supporting that country-led agenda. It's important that we leverage every dollar as we build the case for more financing, which we must, both international financing, domestic financing. We have to be effective with every dollar that we spend. And that coordination both makes it simpler for countries. It also makes that a dollar go further and further by leveraging our capabilities too. The Global Fund is going to double its investments in the next 3 years in community health workers. So we will put something like $1 billion over the next 3 years into supporting countries and supporting national-led plans. We'd love others to join in this coordination, this radical coordination that allows us to do this. So thank you again. We have many partners in this room. We, and I think everyone knows here, are really committed to this agenda. We know that we have to accelerate it. We know that we won't achieve our agenda of eliminating HIV, TB, and malaria without this being successful. So thank you for having me. It's my real pleasure, in the spirit of radical collaboration and coordination, to hand over to David.
Good morning, everyone. Oh, man. So yesterday I was at an event with Angelique Kidjo at UNICEF, and she was like, good evening, and everyone was like, good evening. And she's like, if that's how you're going to respond, the kids don't have a chance. So I was like, fair point, Angelique. I don't call her that, because I don't call her anything. We haven't met one day. So let me try that again. I know it's early in the morning. We all got up. We all rolled out of bed. We made it. We got wet. We are here. Good morning. Okay. Now we're cooking with oil. So it's a pleasure to be here. Last year, I had the honor of speaking with many of you, friends, colleagues, new and old. I had just started this role as the coordinator for the President's Malaria Initiative. And I'm a year older, a year wiser. I have more gray in the beard. I still don't have any hair. And in that year, I think it's notable the progress. I want to pick up on some of what John has said and some of the other speakers have said, Liz, Julius, around the progress that we've made. We've made progress over time, but I've watched it now from this new seat that I occupy. And it's a very different perspective than I had before. And it's a very different privilege and place to be to do the type of work that we're doing to advance our collective agenda. And I want to tell you that vis-a-vis where I was last week and what I was doing last week. So last week, I was in Nigeria with Peter Sands and with John Nkengasong, the ambassador for PEPFAR. We were on a joint visit, and the joint visits are actually rare. It's hard to coordinate all of our schedules, but it was very purposeful because this new administration in Nigeria, led, at least from a health perspective, by the Honorable Muhammad Ali Pate, and this new president, is incredibly inspirational. The president has made health a priority of his, and Muhammad is the conductor of that orchestra. And so the three of us went to Nigeria, had the meetings in the capital, Abuja, et cetera, and then we went to Kano, the state up north, gave the U.S. Embassy a fair bit of gray hair, because it's been a tough place it's just a logistically challenging place to get visitors like ourselves. And during that visit, we were touring a couple hospitals, and we toured a large referral center, one of the largest in West Africa. And they took us to the PICU, Pediatric Intensive Care Unit. And in that Pediatric Intensive Care Unit, it had a bed capacity of around 27. So we're walking through, and all of you who have done this work, which is everyone in this room, has seen this play out. You have incredibly sick, frankly dying children in a hospital bed, dedicated clinicians, too few, who are doing the best they can to save these kids' lives. And out of the 27 beds, all of which were filled, of course, 16 of them were there for malaria. And so I'm, both as a coordinator for the President's Malaria Initiative, but particularly as a human and as a physician, getting very emotional walking through, seeing this scene. When you get into these roles, proximity to patients and people who need care sort of gets larger. And so it was a fresh reminder of what I've dedicated my life to, but also, and here's the rub, a stark reminder that every child in that PICU is a failure of public health. I think about malaria because it is the rainy season for them, so what's the hat I wear? It's the rainy season. It is what they see day in and day out, and every single case could have been prevented. These young lives are being lost before they have a chance to experience anything. We have NETs, we have ACTs, we have RDTs, we have community health workers. We know what to do, we know how to do it, and yet we are failing each and every time that child, either in this worst case scenario is in the PICU, or in the case of the OPD, 60 to 70% of all of the OPD visits, they get 500 a day, 60 to 70% of those are malaria, uncomplicated malaria. And so when I think about that, I think about not only where we are, but where we need to go. There's so much work we have yet to do, and yet, when I think about the challenges, get overwhelmed by the challenges, I think about where I was the week before, in Zambia, with the Bupes. I wouldn't have a chance to meet you, but I was in a country full of your brothers and sisters. And if you think she's inspirational, she is as inspirational as her brothers and sisters. We were out in Zambia, in some of the rural sector, seeing the community health workers do what they do and do what they do in the only way they know how, which is with force and grace and inspiration. And you see the difference that it's making in these communities. You see community-led sort of meetings around what are community solutions for malaria, for example. And so you see these two different opposed, you're in one country, you're in another country, and the next week, and you see the heterogeneity of where we are, the hope and the despair. But years ago, again, picking up from comments from others, we were not in this place. We were having the discussions around the championing of community health workers because there wasn't what I saw in Zambia. There wasn't, even in Nigeria, we did see some great seasonal malaria chemoprophylaxis work with community-based care. And so it's a testament to what you all have done in this room, where we are today, 2023, versus where we were before. Again, progress is not equal, progress is not even, progress is not easy, and we have a lot of work to do. And yet, I think we should all give ourselves a round of applause to where we are today and the tireless work that you all and your teams and your people, and most importantly, the community health workers, have put into getting us here. So let's, a little, not for me. It's give yourselves a pat on the back. But here we are in 2023, and we have a different challenge, but partially, than we did before. What Sheik is advocating for, what you all are advocating for, making professional CHWs the norm, is still our primary goal. But now we're in a different place where it is the how. Implementation is a challenge because, as John noted, as donors, we're lining up behind countries, right? We have, part of the purpose of me being with Peter and John was to have these conversations because, again, as this John mentioned, so much of our work is donor alignment. We're moving beyond the days where the donors are saying, say, to the Honorable Minister, we're going to give you some money, but here's how we want you to do the things that we are asking of you to do. We're moving past that. We make space for the fact that we did that. We still might do that a little bit. But we're moving beyond it to a place where we say and sit with the Honorable Minister of Malawi and we say, Honorable Minister, what are your priorities? Help us understand how you see moving forward, particularly around primary care, community-based care, and the engine of that work, which is community health workers. And then our questions really surround, what are the gaps that you have? How do we help you accelerate progress as a donor community, right? That is a very different conversation. And that alignment are the things that we're working on, not only within the USG, myself, John and Kengasong, Atul Gawande, because these are, in terms of health, you have PMI, you have USAID in terms of the Global Health Bureau, and you have PEPFAR as the primary funders from the USG point of view for community health workers. And then we need to align with our sister organizations, say, the Global Fund and others. Because while I haven't spoken to the Honorable Minister of Malawi about USG and donor coordination, my guess would be that she would tell us we have a lot of work to do. And we're trying to do that work, again, because we're in a different place. We can follow the inspiration of the things that we have accomplished just this year, say the Monrovia Call to Action, right, which we cite, which we talk about, which we are embracing as a way forward, as a beacon, a sort of a waypoint as we move forward. But as we think about how we tackle this challenge, it really is the how, and we're really honored to be joined by the Honorable Minister of Malawi, Khumbize Kandodo Chiponda, and I think I can, yeah, great. I would love if you would join me on stage so we can have a fireside morning chat about the about the how and how the Honorable Minister is moving forward in her country, advancing the work of community health workers.
Thank you.
Thank you so much, Honorable Minister. It's truly a pleasure. We have about 14 minutes to talk, and I want to both thank you for being here, and the first question I want to ask you is, if you could take us through sort of your journey as minister, and as you think about Malawi, the challenges, the opportunities, and how you think about community health workers in the helping you advance your goals for the health of the people of Malawi.
Thank you so much for having me. Good morning. I'm honored to be here, to be part of this very important conversation. There are so many people I have to recognize. CDC is here, but all protocols observed in the interest of time. This is a very important conversation, a conversation which is very close to my heart, because to me, community health workers, they're the backbone of the health sector. So I'm happy that we are making strides globally, not just Malawi. For Malawi, we have really come from far. In fact, for us, community health workers, the way they started as volunteers. We had our first case of outbreak of cholera. That was around 1970s. I think it was 71, 72, 73. And cholera the way it is. When you have cholera, there's vomiting, diarrhea, so it started like just volunteers. I think the communities that time, they had to organize themselves to see how best they could, handle the cholera outbreak. So they started like volunteers. It was just communities mobilizing themselves so that they can take care of the sick that time. So from there as volunteers, and then, issues of vaccination started, so now we had the volunteer vaccinators, because now vaccines, they were available globally for cholera, for so many things, around 70s. So now we had vaccinators. But now the current situation is that we have normalized the community health care worker. So in Malawi, we have what we call health surveillance assistants who are community-based. In fact, we make sure that we recruit from the villages. One, we want them to understand the culture of the community. We want them to understand the language of the community. So they should be part of the community. In fact, they are also part of what we call the Area Development Committee, which is under local government. So that all the information, they are part of the community development. So we have the health surveillance assistants, and then of course we also have community nurses in our communities. So now we have regularized, they are civil servants. They get paid all the perks which a civil servant gets. Our community health care worker, they get. They're entitled to a holiday, they're entitled whatever is for a civil servant, so they are part of the civil service. What we're doing, we would recruit like from high school, then they would go under a 12-week training by nurses, by also clinicians. But now the future is that now we have developed a proper curriculum. Because one of the issues that when you are a health surveillance assistant, there was no like career progression. All of us, you need to get somewhere. I'm a minister, I don't even know what I want to be. But I guess I also need, career progression. So it's the same. They need to be motivated. So for that to happen is we have developed a curriculum 1 year. And that was done by the help of our College of Medicine. Because we want, for us, it is important that the doctor, the nurse, and the community health care worker, they're on the same page. They should not be like, you are taking our job, why are you doing this, why are you doing this? No, there is enough work for everybody. So we had our College of Medicine, which developed this curriculum. They're going to do it for 12 months, and from there, at least, they can, be promoted to something else. We have a normal one, then, they can go as far as the Chief Health Surveillance Assistant, in their career progression. We have done that. as a way of motivating. So we have about maybe 13,000 in Malawi, which is not enough. I would have loved that, at least we have one community health care worker for at least 1,000 people. But now that is not the case. We still need more. Malawi, our population is about 20 million as we are talking right now. So we need more. So it means I'm already talking of the challenges that they are not enough in the community. The other issue maybe which I can also talk about is about to motivate them to do their work better. So it means they need to have equipment, they need to mobility as well, because most of them, we make sure that they live in the hard-to-reach areas, areas where really it is very difficult. The road network is very difficult, but they have to work there. So as government now, we are saying, okay, what is it that we have to do to make sure that we support them wherever they are? So with the help of our partners, and we are very, very grateful to our partners, so many of them to mention, Global Fund, you mentioned, we work with UNICEF, WHO, with the help of our partners, at least we have been providing motorbikes, in other cases even motorcycles as well, for them, the backpacks, each and everyone, they have a tablet, each and everyone, they have a phone. With the help of our local service providers, they have also given them the MiFi to make sure that they are connected. So, and since last month, we have integrated more services. Mainly they do preventive and promotive health, which is very, very important. Because I was telling my Honorable Minister of Finance, I said, if you think prevention is expensive, try getting sick. Sick is so expensive. It is so costly for one to get sick. So we are really into primary health care, more preventive, but more promotive health care. So then to that. So it is about vaccination. It is about community engagement. It is about, so many things. But now we have also added on them to do NCDs. Because all of us were saying, no, NCDs, they're not getting as much support as these other diseases or programs. So now we have given them, each one has a glucometer, each one has also a BP machine, and they are being trained so that when they're going to get to give a vaccine to the child, at least they can also, test the mother for BP or sugar, the grandmother, because they are already in that home for that child. But they might as well also look at the others in the same house. In that way, I think, we are going to do more in terms of primary health care, but also as all of us were trying to attain universal health coverage. So let me stop there for now, because I'm talking.
Thank you, Honorable Minister. An incredible summary of what you have done and the achievements that you've been able to move forward under your leadership. So I think I speak for all of us in this room when I tell you we're incredibly inspired by your leadership. Thank you so much. You've painted a beautiful picture of what the community health workers are doing, their curriculum, career opportunities. So many of these things are things that we all talk about. In addition to that, one of the things that I think we're all curious about of the how is, and you mentioned your colleague, the Honorable Minister of Finance, the dialogue between yourself and the Minister of Finance, because so as I talk to ministers, for example, I don't think I've spoken to a minister of health who is not enthusiastic about community health workers. But then when we talk about payment, they change the subject, they deflate, and I empathize, because it's very difficult to imagine putting a whole new cadre of folks and creating and putting them in the civil servant category, right? It increases your budget line not only today, but indefinitely. So I'd love to understand how you tackled that challenge, right? Because, so many of your brothers and sisters who are ministers have this similar challenge, but you've been able to overcome that. And if you could take us through how you did that. And then the second part of that question is, you mentioned 13,000 community health workers, and your
goal to expand. But as you expand, obviously, you're going to, you have to pay these community health workers. So also, the second part of the question is, how do you envision sort of those types of conversations, and will payment limit your ability to expand?
Thank you so much. It's never easy. It hasn't been easy, and it has happened, but after a conversation which took years and years, it didn't just start now, but it has taken some time for us to reach to that stage. But I think one thing is that, COVID taught us very, very many lessons. That globally, you can just shut down. Whether you like it or not, when a pandemic hits, you can literally, countries, they shut down. Everybody else, they were locked in their houses, but it was only a community health care worker who took the risk of going and helping the patient. That's how important these people are. So we really need to appreciate the services which they render, and our colleagues in the Treasury or Finance, they also need to appreciate. So we are coming from that background that they appreciated. I understand very well when we are having a conversation in our countries, there are so many priorities. Education is number one. All of us want to put education, we want to put our children in school. In fact, I would also support education, because I know the more people who are educated, the less cost on us as a health sector. Because when you teach a girl or a boy, they'll be able to take care of themselves. They don't even have to come to the hospital. So I support fully that we really finance education, because education is a game changer. So there are so many priorities. Education is a priority. Agriculture is a priority. Then you have gender and children. It is a priority, as well as health is also a priority. So we have that, but we understand. I know our fiscal space is very, very, very tight. As a country, we are even unable to match the Abuja declaration of at least having 15%. We hover about maybe 9, 10, or 11% of the national budget going to the health sector. We understand. So one way which we are trying to overcome this is that now we have started a health financing dialogue. As our partners, Global Fund, all our partners, bilateral partners, UK, Germany, Norway, all of them, we have started this conversation about how do we put more in our resource envelope. Not just waiting for my Honorable Minister of Finance, but ourselves also need to do our part. So we have started this dialogue. We launched it last year, and we are very happy. Even the private sector, the citizens themselves, they're also part of the conversation. Because all of us, we understand that, no, we need to do something more. It should not just be government. Even civil society groups, they're also part of the conversation. We need to have a conversation. What is it that we have to do so that we get more in our resource envelope? So it is ongoing conversation, but I'm happy that we are talking about it. I think it is very important that all of us, we have to agree that there isn't enough. But then finding a solution, it should also be a collective responsibility as a country to find a solution.
Thank you very much. That's really, I think, inspirational to help us think about how we can continue to support your goals. To that end, as a representative of the U.S. government and heading a presidential initiative that contributes to the payment of community health workers, what would you say to me and my colleagues in the U.S. government and, say, at the Global Fund, in terms of, as I mentioned earlier, how can we better align ourselves to support your vision?
Okay. A very good question, and I'm happy that you have asked it. I was looking for that opportunity. So Malawi, now what we have done, the other thing is that we have launched a new health sector strategic plan, which we are going to use from 2023 up to 2030. So in that plan, the main thing is that we have developed a plan in the health sector for the country. So we have one plan, we want to have one resource envelope. So it's one plan, one budget, and one monitoring and evaluation. We are pursuing this because we, having reviewed how we have been doing things, our strategic plan number 2, which has just expired, we reviewed it, we saw the gaps, we saw the challenges, and we've said, okay, how do we overcome this? We have got so many successful programs. Our HIV management, AIDS management, tuberculosis, even malaria, we have done so much. But we also have some areas really that we are not moving. If anything, we have gone backwards because of lack of support. So what we want is that as a government and our partners, we should go by one plan. So what we want is that we need all of you to support our plan. Let's put resources together, in one envelope, and then government, you can say, okay, at least mental health. I don't have anybody who is supporting mental health, but from this envelope, this is how much goes to mental health. There are so many issues. There's mental health, NCDs, the neglected, we still have neglected, diseases in Malawi, and literally there's no support. And of course, now we have emerging things which we thought they were done with cholera. We're just coming from the West Cholera outbreak, whereby 1,700 Malawians lost lives only last year. So we have emerging issues, measles, what, there are so many things which are emerging as well, and they will not get any support. So that is why we're saying, no, all of us, let's sit around the table, we follow a plan, we develop a plan, because as a government, we know what is good for our country. So we want everybody who's coming into Malawi to support us in the health sector. They have to go by our plan, but we need to pull our resources together. We need infrastructure. There are some women who still have to walk 10, 15 kilometers just to have an access. You were talking about Nigeria, whereby you go to a hospital, there are so many children, sometimes you have 3 or 4 children on one bed, So things like those, which we have to address. So that is why we're saying no. But if we put our resources together, we know exactly what needs to be done. So what we want from you is, to support us. Thank you.
Understood. I think what you've said is critically important, and one of the things that we're trying to align around, which is one plan, one budget, one M&E, right? Not a donor prescribed plan, et cetera. And so I can commit to you, on behalf of myself and my colleagues, we are going to continue to do better on that score and follow your lead as you as you move forward to improve the health of the citizens of Malawi. So thank you. We have time for one more question. And I guess my question would be to you you have this incredible group of folks from many different places in the world, community health workers visiting us from Zambia. We're all fighting to advance community health worker engagement, community health worker, making community health workers, as you have, central to a country's plan to improve the health of her citizens. And so what lessons would you leave for us? What can we do to be in service of you better? How can we improve our work to support what you're doing?
Thank you so much for that question. And let me say thank you to all of you who are supporting our community health workers, or initiatives of supporting community health workers in our countries. We really appreciate. There are so many challenges. Bupe has really explained it very well on what they go through. So the lessons I would want to share is that the first one I've already said it, is that we need to support country programs or country initiatives. We need to support them. And the other thing which I would want is that we need to be explicit of what kind of support we are saying. Because sometimes it's so frustrating. You attend the meetings, you're hopping from one meeting to another, and then when you go back home, you sit down and say, what really have we achieved? So it's frustrating because sometimes we don't articulate properly what kind of support. Because I need to say, okay, you want to support us, okay, what do I need? I need to recruit. We'll say, okay, we'll help you to recruit 100. Or what is it you need? I need training for my health workers. Okay, we'll be able to support 100 to go through this training. What do you need? I need equipment, I need bikes. These are the things which we need. So there's so much support in the health sector. There's so many health initiatives supporting us from the least developed countries. But you cannot, I don't know what to say. You cannot say, okay, for this year, this is how much has gone to that country. For me in Malawi, I want, when you're supporting me, when you come to Malawi, I'll say, okay, these 100, they were supported by you, training or recruiting. That house for the community health workers in this village, 3 houses, this is what we did with your support. We want things on the ground. We don't want just meetings in here. No. So take that message from me, speaking on behalf of everyone else.
Action is what we need. Action. We are out of time. I want to thank you so much for sharing these words of wisdom, this counsel to me, my colleagues, and to all of us in this room, and for sharing so much of what you have. I'd like to ask all of us to give the Honorable Minister Chiponda another round of applause. And thank you for waking up so early to be with us today. And I'll turn it over to Madeline.
Thank you so much, Honorable Minister, and David, and Bupe, and Liz, and Julius, and all of today's distinguished speakers, including John. No, all of you today have made the possible into the actual. And for that, we're very grateful, and I think we can give them another round of applause. So we find ourselves in an era of remarkable transformation. Just a few short years ago, when the coalition began, it has to be said that the pro-CHW agenda, the idea of professional CHWs, was the subject of heated debate. We were told, oh, this is the Cadillac of community health worker programs, as opposed to just the car, just what's required to reach patients. And I'm excited to say today, on the table in front of you, you have a copy of the Monrovia Call to Action, and that states clearly, the evidence is cleared, salaried, supervised, skilled, supplied community health workers must be the rule, not the exception. And we're proud as a coalition for the role that we've played in driving this consensus through our collective research, advocacy, CHW organizing. And if you've ever heard the stat that Bupe shared, 86% of CHWs on the continent of Africa are unsalaried, that's chic. If you've ever heard that 1/3 of CHWs are out of stock, or out of stock 1/3 of the time and much more than their facility-based colleagues, that's chic. And if you've ever heard that CHWs, pro-CHWs, maintain essential services during pandemics, that is chic. And so it's clear that while the notion of pro-CHWs is certainly in the ascendant, it's also clear that it hasn't yet happened. This year, the coalition launched the pro-CHW policy dashboard, which you'll see on the screen in a second. And that dashboard is the largest public-facing database of pro-CHW policies globally. It's a scoreboard for the field to track progress and to spur policy change. And as you can see, it's a little small, but the current score is 34 countries with pro-CHW policies to 57. And that's without counting a number of countries for whom we're missing data. So while it's clear that paying CHWs and including CHWs in policy deliberations are technically sound positions, it's also clear that these remain disruptive claims in the current context. And so to close today's event, I'd like to offer 3 invitations to this room in what I think is a pivotal role, or potentially a pivotal moment if we choose to make it one. First, I'd invite us to get comfortable with controversy. You know, it feels pretty good to be in this room. We have a nice view. Everybody agrees with us. We're clapping. We're patting ourselves on the back. But what about when it starts to cost you to be a CHW advocate or a CHW ally? When you're in a more hostile or indifferent room, where it's easier to go along to get along, to say nothing, or perhaps to just quietly turn your attention to the next big thing. Klein reminds us, first they ignore you, then they laugh at you, Cadillac, then they fight you, then you win. And I sense that we are transitioning from a season in which our movement is in vogue to one in which its implications that we've heard discussed today, that, as the minister said, requires intense upfront investment, that, as John and David has described, requires a change to RFPs as usual, that these implications will be met with resistance. So what is our plan for rising opposition? For the moment in the meeting where enthusiasm about CHWs joining the conversation morphs into offense at what they actually have to say. We need to stand strong in the discomfort, and we need to do so long enough to win. My second invitation is that we would do this with humility and a spirit of inclusion. We were really excited to see the pro-CHW movement profiled this week in Foreign Policy. You guys will all get a copy of that article following this event. And when I was being interviewed for that story, the journalist asked me, who are the baddies? Who should we be naming and shaming in this article? And I think I disappointed him. Because I said no one. No one's the baddie. Because global financing institutions and guideline makers and those 57 ministries of health did not wake up this morning with malice in their hearts. They are just people, and they are responding to less than ideal incentives. And that's why we as a coalition are so focused on changing guidelines and funding and policy, because we believe that when the game changes, so do the players. I think that our victory in this movement, which is coming soon, as we've heard, will not be a triumphing over. It will need to be a triumphing with. In order to turn this map purple, we will need to have a spirit of generosity, a willingness to collaborate, and that's what's going to get us there. And we're all ambassadors for those convictions, and I hope we can continue to forge a movement that reflects them. And my final invitation is that we would hit the accelerator, guys. Resistance is coming. Resistance is definitely coming, but at the meantime, we are on the agenda. We are living in a time in which every secular trend, from the pandemic to the renewed attention on labor conditions, to the rising tide of the women's movement around the globe, sets us up to win, and it sets us up to win now. Today you've heard from community health workers, from ministries, from funders on the vanguard of this movement. And my invitation is, if you're not already part of it, join in. If you're thinking about investing, invest now. If you're thinking about organizing, organize now. And if you're thinking about legislating, I think there's someone in this room that can help you with that. Together, we have put professional CHWs in the spotlight. It's now time to take action and make them the standard. Our coalition, I'd love for you guys to stand up. We're ready. We've been working. Our coalition is ready. Will you join us? Thanks so much, everyone. We'll have a chance to gather, to continue eating, to pick the brains of our wonderful speakers. Thank you so much for getting up early with us today, and we hope you'll join us.